going. Welcome. My name is Michelle Morand, and I'm here with Alexandra Rowland. We are the co-founders of a private cancer research and advocacy group called Cancer Treatment Options and Management. And for over 11 years now, we've been helping people all over the world, specifically Canadians, to access the most current cancer treatments and most beneficial cancer treatments for themselves. And 99.9% of the time, we're actually able to do that through their current oncologist and covered through public health care. So what you're here today to learn is what are the most current and beneficial treatments for pancreatic and bile duct cancers, and how can you start getting access to them? What are the steps that you need to take in order to make that happen? So we are, I'm going to be presenting on my little side of the screen here. I'll be presenting a PowerPoint that we made to help illustrate some of the things that are most important for you to know about what's possible in cancer treatment today and how to get access to it. And Alex will talk us through some of the most critical elements of understanding diagnostics in cancer in 2021, and also most important treatments for you. And we will take questions. So go ahead and post your questions in the chat as we go. And certainly we'll leave some time at the end of our presentation to have some time to talk with anybody who wants to share a little bit about your case and get some guidance from Alex about that. Is there anything you want to say before we kick off, Alex?
I think you've pretty well covered everything. You know, a lot of what we're going to be talking about is the basics of precision oncology, such as tumor DNA sequencing and the new diagnostic technologies that apply to all cancers. So we're going to kind of skim over that with the hopes that everyone can do some background reading on that, and then we'll cut straight to the actual advances in pancreatic and cholangiocarcinoma. Okay,
so we'll do a little skim. The PDF that is loaded in the chat and which will be coming to you in your email, it has all sorts of links for you to explore. And then again, everything we're going to share in the PowerPoint and then some. So don't feel like you need to take notes. You can just relax and focus here. All right, I'm going to share my screen here. Okay, all right, view. Oh, there we go. Slide, let's start. Okay, here we go. All right, so let's see here. So today we're going to cover what these types of cancer are, how they form, how they're treated in standard care, and then we're going to talk about what's so possible now and how to get access to it. So Alex, do you want to tell us just a little bit about these two types of cancers?
Sure, yes, by all means. So pancreatic cancer, I'm sure everyone knows what the pancreas is. So pancreatic cancer develops in the cells of the pancreas. There's a few different types of cells it can develop in, but the most common types are exocrine and neuroendocrine cells. And then the exocrine type, which is usually called an adenocarcinoma, is the most common. Pancreatic neuroendocrine tumors are less common, and they have a much better prognosis because they're a different type of cancer really than the adenocarcinoma. So we're not going to cover treatment of neuroendocrine pancreatic cancers. We'll be doing a separate presentation on neuroendocrine tumors because neuroendocrine cells are all over the body. They affect all organs, and they're pretty well treated the same way regardless of which organ they occur in. Can you go back a slide, please?
All right, I didn't mean to do that. Hang on a second, gonna go back. There we go.
Yes. So once again, neuroendocrine tumors are less common. We're not going to be covering those today. We're going to be covering the adenocarcinomas because they're really the most common and the hardest to treat. And then bile duct cancer. There's a few different types of bile duct cancers. They're kind of grouped into a type of cancer called cholangiocarcinoma. And they basically occur in the ducts that pass these enzymes into the intestines. So, you know, there's a variety of different ones. We'll be looking at intrahepatic mostly today. Extrahepatic is a slightly different type, but we'll be looking at a few examples of advanced therapies in cholangiocarcinomas today.
All righty.
Ding.
Yes, now let's get that. Come on, you, there we go. Oh, is that right? Hang on a sec. Let me get, I don't know what's happening with my show here. There we go. There we go.
There we go. So yeah, I'm sure most people understand what the risk factors are. They're pretty common in different cancers. Definitely workplace exposure. We see more pancreatic cancers in dry cleaners and certain types of factory workers. Exposure to certain chemicals. We see them in the oil fields of Alberta, where people are exposed to different carcinogens, being overweight, smoking, having type 2 diabetes, which is a health risk factor in itself, chronic pancreatitis, age, being a man, and also, being African-American, you can get a higher incidence of pancreatic cancer. A small percentage are inherited. So typically when we see an inherited version, it's based on a defaulted tumor suppressor gene that's been passed on. And this is typically in patients or people that have had a cancer before the age of 50. So someone who has cancer in their 30s or 40s is almost always an inherited based cancer. Also, there's food, there's a food issue. Basically, the pancreas is involved in breaking down foods and providing certain types of enzymes that will break down foods. So when you have a diet that's heavy in saturated fats and processed meats and red meats and so on, it really requires the pancreas to work overtime. And what happens is every cell in the body has a finite amount of times it can reproduce. That's referred to as a Hayflick number. So you basically end up burning out your pancreas by having a diet that's heavy in red meat and saturated fats, because it requires so much work from the pancreas. So what happens is eventually the pancreatic cells, they reach their Hayflick number and they start deteriorating, and that's when the ends of the chromosomes start deteriorating and they start developing more mutations. So it's like, think of a diet as heavy in saturated fats and meats as a way of prematurely aging your pancreas.
Interesting.
Yeah.
Hang on a second. There we go.
Okay, cholangiocarcinoma, a little different. There's a few different things that can cause it: chronic liver disease, bile duct blockage problems at birth, irregular bile ducts. Liver parasites are very common in Southeast Asia and tropical countries. And this is one of the biggest causes of this type of cancer. Now, it creates a different subtype than what we see in North America. The genetics are different. The molecular features are different because it's caused specifically by a parasite rather than a host of different carcinogens or, burnout. So that's we're not going to be covering the type of cholangiocarcinomas that are caused by liver parasites, because they're just not that common in North America. Then smoking, obviously, diabetes, and then certain inherited conditions. Once again, Lynch syndrome, where you have a deleted PTEN gene, that can be an increased risk.
Okay.
Yeah.
All right.
So, one of the big questions I hear a lot, excuse me, is why do pancreatic cancers have such a poor prognosis? And this is really important, because understanding how a cancer is caused, its molecular features, and why it is in the organ it is really important into determining how to treat it best. So one of the biggest issues with pancreatic cancers is there's a few different things that cause them to have such a poor prognosis. But one of the big issues is it's really the location of where the cancer occurs. So typically by the time you detect a pancreatic cancer, it's difficult to get surgery, and surgery is the most curative form of treatment. Getting the cancer out of the body before it metastasizes is everything. So in locally advanced pancreatic cancers, and those are ones that are not metastatic, In other words, they're just in the pancreas. They haven't spread to other organs. They typically involve something called the superior mesenteric artery and the superior mesenteric vein. And those are really difficult to do surgery around. And so this prevents surgery in most patients. And I think even in, locally advanced, low stage cancers, only 20% can have surgery. So, when you have surgery, it significantly improves your overall survival. So for example, patients with unresectable, in other words, if they can't have surgery, they only have a median survival with treatment and chemotherapy of 6 to 10 months from diagnosis versus 23 months if they are able to get surgery. So obviously surgery is very important, and the location of the tumors and the way the pancreas has its arteries and veins structured around it, it really limits surgery. So if you can go to the next one. Another factor, you often hear how pancreatic cancers don't respond to chemo very well. And the big problem is really, and this is unique to pancreatic cancers, is that they're surrounded by this network of cells called stroma, and it acts like a real barrier to treatment. So as little as 10% of the tumor volume is cancer cells. And that's a very interesting thing. Normally we see anywhere from 20 to 50, 60% of a tumor is cancer cells. But in this particular case, with pancreatic tumors, pancreatic adenocarcinomas, 10% is a very small amount. And what this tells us is that there's a lot of other cells in the tumor microenvironment that are contributing to the growth of pancreatic cancers. And this matrix also causes blood vessels to collapse. So these proteins called metallomatrix proteins that are in this tumor microenvironment, and they cause the blood vessels to shrink. And this prevents the chemotherapy drugs from reaching the cancer cells. So a big part of the problem with pancreatic cancer, number one, surgery. It's hard to access. Number two, it has this protective barrier around it, around the tumor cells that prevent chemotherapy and radiation therapy and other drugs from actually reaching the tumor. So next slide. So, and one other thing, when pancreatic tumors metastasize, they take this matrix with them. So they have this unique tumor environment, regardless of which organ they're in. And so, a metastatic pancreatic cancer is just as hard, the tumors are very difficult to treat, the metastasis. So the standard care is typically, blood markers such as CA19-9, not always a reliable marker. An endoscope, different scopes, surgery, CT scans, MRI, biopsies, and then standard pathology. The same with most cancers. Next slide.
This is for the diagnostics, not the treatment.
Yeah, what diagnostics involving the treatment? You want to know what type of cancer you have in order to determine which treatment is best.
All right, so a little bit about CT and MRI, Alex?
Yeah, so there's a lot of information on our websites, on the Cancer Guy YouTube channel, which I suggest you go to and read up on CTs and MRIs and PET CTs and understand why they're different. So in short, most imaging uses like CT scans and so on, CAT scans. Typically, they blast a beam of radiation through you, and that radiation gets caught up in different densities. So let's say you have a thick lump in your pancreas, and they blast a beam of radiation through you. Then they have a detector on the other side of the body. And if some of the radiation is absorbed by a tissue with different density, then that's detected on the other side of the detector of the CT scan, and they tell you that you have a lump. Both CTs and MRIs, now MRIs use a magnetic field that polarizes water molecules. It works in a slightly different process, but it still works in a similar manner. And in both cases, what this type of imaging does is it presents you with a block of tissue or a lump that is a different density, but it doesn't tell you whether it's cancer or not. It just tells you that this happens to be a tissue of different density or a lump of different density. It doesn't tell you if it's benign or tumor or not. And you typically require a biopsy. But there is another way. If you could go to the next slide, Michelle.
Mhm.
So PET-CT, it's been around for quite a while. It's a great tool. Most patients with cancer should be getting a PET-CT. Basically what it does is they inject this radioactive sugar solution into you, and it only lasts about 8 to 10 hours in your body. And what happens is since cancer cells are constantly growing and constantly eating and metabolizing 24 hours a day, they never stop, and normal cells do, then the tumors will drink up more of this sugar radioactive solution. And then what they do is they give you a CT scan. So anywhere there's any small amount of rapidly reproducing cells, they're going to glow like Christmas tree bulbs on a Christmas tree. And it really is a great tool to tell whether a lump is cancerous or benign. More importantly, it uses this measurement called SUV, serum uptake value. And this serum uptake value is basically how much of that radioactive isotope a lump will drink up. So a more aggressive one will drink up more of this radioactive solution than a less aggressive one. So one that's growing faster, one that's metabolizing more, a more higher grade cancer is going to be identifiable. So you can actually tell which tumors are dead and responding to treatment. You can tell which tumors are not aggressive. So you may have a really large tumor detected on a CT scan that your doctors are focusing on, but it could be mostly necrotic. It could have a very low SUV. It could be on its way to dying, and it can be targeted for treatment incorrectly. So a PET-CT scan is really, really important. And so Michelle's done some statistics here about PET-CTs. So there was a lot of studies, but recently there was in the local cancer agency here in British Columbia reported that when patients get an external PET-CT, in other words, a private PET-CT, it changes oncologists' treatment plans in 80 to sometimes 90% of the time. There is a bit of a problem with PET-CT, is it's not a cheap process. So it's more expensive than CT scans and MRIs, but really it is well worth the extra cost of it. But Canada is not that far ahead when it comes to diagnostics. What's the statistic here, Michelle? You want to explain that?
This is from 2016. This is from 2016, although it is pretty much the same. I just checked their 2021 most current. And essentially, when they surveyed 28 countries with public healthcare programs in terms of how they provide cancer care, Canada is listed as 23rd out of 28 for our diagnostics for cancer. Yeah. In terms of how the quality of the diagnostics we use and how accurate our diagnoses are. So the main piece here is with standard diagnostics like CT and MRI, you don't even know for sure if it is cancer, and it takes repeated scans over many months in order for your oncologist or GP or whoever is doing this for you to assess whether something is growing or not and whether it's problematic or not. Whereas with a PET-CT, it's, you have one scan and within 24 to 48 hours, Exactly. Just this week, for example, we had a fellow who had his PET-CT on Wednesday, and Friday morning we had the results, and we could consult with him and tell him with absolute certainty what is and isn't going on in his body, where it is, and what his best next steps are. So there's a big difference between 3 to 6 months and 48 hours.
Yeah, and I think you made a great point there. This case that Michelle was referring to, the person thought that he just had localized cancer. He didn't know it was metastatic, and his doctors were about to treat him as a localized cancer. So when we did the PET-CT, we found tumors all over his body that were missed. Sadly. And that radically changes his treatment plan. So had he not had that PET-CT, he probably would have a very poor prognosis because he was on the wrong treatment.
Yeah.
Next scan.
I think we've made the point. Get a PET-CT.
Yes, we made the point. Get a PET-CT.
And there are a number of private scanning clinics.
Yeah.
If you can't get one through public healthcare, well worth it. Yeah.
So biopsy, obviously very important. It helps you determine what type of cancer. You can go to the next slide. Pathology. this is pretty standard care stuff.
That's okay, Alex. I just want to say the reason I include this slide in our presentation is because sometimes people don't necessarily understand, the process of diagnosis. So understanding that initially there's maybe a scope, and then maybe a scan, and then maybe a sample of tissue will be taken from your body. And then there's about however long that takes, there's about another 2 weeks or so often waiting from the time that sample is taken to the time the pathology lab does their standard pathology with it to essentially make sure it is either benign or malignant, and then start to differentiate a few characteristics to help to inform the oncologist for treatment. Yes. So mostly what I want people to understand about this is it's another layer of the onion, or another piece of the process, and pathology is very important. We're going to talk about that when we get to precision oncology a little bit more, but it's another delay. And again, as we're going to talk about in a little while, it's important that you make the most out of this phase of the diagnostic process as well, not just the imaging with the PET CT versus CT or MRI, but how you take care of the biopsy.
Exactly. Yes. Good point.
So let's talk about standard treatment. It's pretty limited, so it'll be fast.
Yeah, and this has recently changed. So typically surgery, if you can get it, as mentioned, even with local advanced tumors, surgery is only an option, 20-25% of the time. There's also the location of the actual tumor on the pancreas is important. I think I missed that slide. I apologize. But you can have it on the head or the tail of the pancreas. And so typically the head has a better prognosis than tumors on the tail. It's quite significant. They respond better to treatment fairly significantly compared to tumors of the tail. And that, once again, that has a lot to do with the location. So location is very important here. So the standard treatment, surgery. And then recently, there's something called FOLFIRINOX, which is a combination of two colorectal protocols. Now, for this, they use what's called a modified version. So you're basically getting 3 drugs that are used in pancreatic cancer, that are used in colorectal cancers. It's probably the modified FOLFIRINOX is probably the best chemotherapy protocol. And then you typically get followed up by a drug called gemcitabine, and then another drug called paclitaxel, and then radiation for metastatic lumps and so on. Typically with, there's a good point here that bile duct cancers are lumped in with pancreatic cancers. So typically they use a lot of the same sort of chemotherapy protocols for them. Next slide. So standard care, first and second line treatment for cholangiocarcinoma, as mentioned, is if you have advanced intrahepatic cholangiocarcinoma, you get cisplatin plus gemcitabine. The medium survival for 50% of the patients is about 1 year. It's not the best. When you get second line chemotherapy, typically 5% of patients respond to second line chemotherapy, and the average survival for that is 6.2 months. So not a good prognosis with standard care. The next slide. So precision oncology, and this is where cancer is right now. Precision oncology, basically, it's been described as the right drug for the right patient at the right time. And Michelle has created this system called the 4 pillars, which I think is really a great system. It starts with genetic and molecular testing. So DNA, analysis of DNA and RNA and different things that have caused the cancer. And then personalized research, which changes literally on a weekly basis. So you can have new studies coming out every week for every type of cancer. And then targeted therapy, finding out what mutations need to be targeted, what drugs are going to be best for the person, and then treatment monitoring, determining whether the treatment is working or not without having to wait to see if the tumors have grown or not. Okay. So Michelle, did you want to cover some of these?
Sure, I just had myself muted because the dogs were barking up a storm out there. Sure, I can run through this part. So we all hopefully know now, if you're here, it's because either you or someone you really care about has cancer. And so chances are you've done some Googling, you've done some searching, you've done a little self-education. Your local cancer agency has probably given you some resource materials to help you better understand the type of cancer and you know, kind of what to expect. So you should know now that cancer is caused by mutations in your genes. Something's gone sideways, and we'll talk a little bit more about that specifically down the road, but something's gone a little sideways, and now things aren't working the way that they should, and so cancer has formed. So the most important thing to remember about that is that if you have cancer, it means that there is some sort of mutation process that has occurred. In other words, you must have some sort of genetic mutation. And the reason I'm belaboring that point and saying it 5 different ways is because a lot of the people that we speak to, when they reach out to us, they one of the very first things they say is, my doctor says I don't have any markers for cancer. How can you possibly help me? Or my doctor says that I can't get targeted therapy or immunotherapy because I don't have any genes in my cancer. So I want you to just really be really well educated that that's not possible.
No.
Physiologically, you must have certain mutations, and most people have a handful of them, not just one. So if your doctor is saying something like that, it means that worrisomely, maybe they don't understand cancer, but probably more like it, they're not able to get that type of testing for you. So I just want to really make that point. Oh, hang on a second. So if we think about those 4 pillars, the first one being really just get the most thorough diagnosis that you possibly can. And in cancer care right now, that looks like a lot more than just what we ran through with the basic CT and MRI biopsy and pathology. One of the main elements of getting the most thorough and accurate diagnosis is making sure that you have proper genetic and molecular testing. And right now there are 7,000 different genetic tests out there on the market, 7,000. So if this isn't your wheelhouse, and especially if you're stressed because someone you care about or yourself are struggling right now with a potentially life-threatening illness, how do you figure out which of those 7,000 companies actually has what it is that you need? So that's essentially what we're here for. But what we've done here is we've just made a little short list of details and types of tests that you really want to make sure that you add to your diagnosis to make sure it's as accurate as it can possibly be. So first off, there are 3 things you want to make sure that whatever testing you have done covers. And these 3 elements are fusion genes, mutations, and overexpression, which might sound like gobbledygook. Remember, the PDF that you have has lots of detail about this, much more than we're able to share in the slides. So you will be well educated by the time you're done reading and exploring that. But Alex, let's talk a little bit about these. If you could just briefly fill us in from your science background.
Great.
Fusion genes, what are they? Why do they matter?
First off, I think you did an excellent job there explaining it. So cancer is a disease of the genes, as we know. We have genes are basically groupings of pieces of DNA into a bunch of different substructures called a gene. And genes are turned off and on as they're needed because they produce certain elements that create biological life. So we have 25,000 genes in our genome, in the human genome, roughly. And you only need to mutate 4 of those genes to turn a normal cell into a cancerous cell. There are 4 specific pathways, but if you mutate 4 of these genes, 1 in each of these 4 different pathways, then you will get cancer. Your normal cells will turn into cancer. So the earlier you catch a cancer, the less mutations it has. As time goes on, then the cancers develop more mutations. So what happens in most mutations, there's 2 types of genes. There's what we call tumor suppressor genes, and they're turned on all the time, 24 hours a day, and they protect our bodies against cancers from developing. There's a bunch of different genes that are involved, and what they do is they detect any cell that happens to be rapidly reproducing more so than other cells around it, and they will go in and shut that cell off if it's rapidly reproducing. Then we also have what's called oncogenes, and these are genes that are involved in growth and development and healing damage to our body. And basically what they do is when they get turned on, they cause the cells to reproduce certain tissues. So if you cut yourself, these genes get turned on and they will replace the skin cells that have been damaged. And then as soon as that's done, they will get turned off and they won't get turned on again. So cancer is a combination of turning mutations that cause damage to the tumor suppressor genes so they can't function anymore. And it also causes oncogenes to get turned on when they're supposed to be turned off. And so you get this duality, and I like to think of it as the gas pedal and the brakes on a car. You know, the tumor suppressor genes are like the brakes on a car, and oncogenes are like gas pedals. So you need a gas pedal to go up a hill. You press on the gas pedal to go up a hill, and then you get to the top of the hill and you take your foot off that gas pedal and your gas pedal is damaged and it stays on full blast. So then you go to hit the brakes and the brakes are broken. So that's basically an analogy of what cancer is. It's like having the gas pedal of the car on full blast and having the brakes broken. So what is a fusion gene? A fusion gene is basically just a type of mutation. And what it is it's the control region of a gene that's turned on all the time, like a tumor suppressor gene, gets actually spliced onto the actual gene component of a gene that's not supposed to be turned on. So a gene that causes growth and development, for example. And let's say this gene is only turned on briefly at certain times in your life. Well, what happens in a fusion gene is the control region that's always on, a light switch, for example, that's always on, gets accidentally attached to a gene that is supposed to be always off. And so now you have this gene that is supposed to be turned off, turned on, and it's turned on permanently. So that's what a fusion gene is. Next slide. And so mutations. So mutations are basically in cancer, they either stop the gene from functioning if it's a tumor suppressor gene, or they will cause, if it's an oncogene, then what they will do is they will cause the gene to stay stuck on full blast. And so all of a sudden, this gene is attached to its partner. It's only supposed to be attached to its partner briefly, but this mutation causes it to get stuck to its partner. And so you get what's called constitutive signaling. In other words, the cell is constantly signaling to growth and to grow and divide and produce more cells, and it's stuck in that mode. The next slide. And then you also have something called overexpression. So this is something that affects the control region of the gene. Basically what overexpression is, it's an epigenetic mechanism. So our cells have the same DNA. Every cell in our body, regardless of the type of cell it is, has the same DNA, but it looks different. And the reason it looks different is because there is different gene expression. So in your skin cells, you will have certain genes turned on and other genes turned off compared to your blood cells or your retina cells or different body parts. So there's differential gene expression in all of our cells, and that is controlled by something called epigenetics. And so epigenetics basically is the way our body uses the same DNA template and the same genes to create different cell structures. So, theoretically, we could have the genes in us to grow a tail, but they're just turned off, and they're turned off permanently in our bodies. So if they got turned on, then, we would potentially grow a tail. Now that, of course, is, very Jurassic Park-ish, but that is the theory. So what happens in overexpression is your tumor cells will have much higher levels of certain genes than they're supposed to. And that's caused by epigenetics. So next slide. So as Michelle said, there's 3 types of testing that are really important for everyone with cancer and that are the basis of precision oncology. They are tumor DNA sequencing, where you look at the mutations in the DNA of the tumors, and compare them to the normal cells in your body. There's RNA expression testing, where you look at the amount of the gene. And the way you do that is you look at something called messenger RNA. So you look at the level of the RNA that's being produced in the tumor cells of all the different genes, and you compare them to normal cells. And then there's something called inherited mutation testing. And this basically refers to whether you've inherited a damaged tumor suppressor gene or not. Okay, next slide. So yeah, tumor DNA sequencing, we've briefly covered this. There's tons of information on our website. I'm not sure if we need to really go over this, but basically it just looks for mutations, damage to your genes in your tumor.
I think one of the most important pieces for people to understand why we're bothering to give you this information in this presentation is because right now, and we're going to talk about this very shortly, there's a whole new way of treating cancer. It's really actually quite exciting in terms of how we are now able, because we have this new innovative technology that allows us to do this type of genetic and molecular testing. Pharmaceutical companies can now design treatments that are specifically targeted to these most common genes or mutations that we're finding in cancers. And there are just there's hundreds of those treatments available right now, and many more coming out all the time. So without this type of testing that we're talking about here, your doctor can't with confidence prescribe you any of those targeted therapies or immunotherapies, because they don't know which ones you need, and they can't have confidence that they're going to work for you. So this testing is really a critical element in making sure that you get on the right treatment, because treatment has really evolved from standard chemo, radiation, and surgery to hundreds of different targeted therapies if you only know which mutations that you have. So the genetic testing, the tumor DNA sequencing is one key element of that diagnostic protocol, so that we can find out, okay, in your tumor cells, and this can be done with blood or tissue, what mutations are present. And some of the best tests on the market right now look at 500 to 600 genes. Oftentimes in public health care, people are given a test that looks at 2 or 3 commonly associated genes, maybe 20. So if your doctor has said, again, we've done testing for you and you don't have any markers, ask them how many genes they tested for. Chances are the panel that they used in your local public health care program, if they used any, looks at a very small number. And there are many more that can be looked at. So in tumor DNA sequencing, you're looking at tests that look at between, again, 500 to 600 known mutations. In RNA expression testing, or the overexpression testing that Alex was talking about just a moment ago, this test looks at over 20,000 genes. Alex mentioned we have 25,000 genes in the human body. That's pretty much all of them. And it's looking to see, based on kind of normal tissue expectations, where are you showing up? Which genes have more of a certain gene being expressed than they should? And that helps us to zero in much more efficiently. If you think of the tumor DNA as getting you in the ballpark, think of the RNA expression testing as getting you to that bullseye right away. So using the two together gives you a very thorough diagnosis.
Yeah, and just to summarize what you said there, Michelle, I think a lot of people don't understand this, but we identified the human genome. We're able to figure out all of the structure of the human genome in about 2005. And so since we did that, all of the drug development in cancer and many other diseases has been based on certain molecular features. So what happens is scientists will find a certain mutation is common in a certain type of cancer. And then they will develop a drug that will kill any cell with that mutation. So standard chemotherapy that we talked previously about, those are pretty old drugs. The way they work is they will kill any cell that happens to be copying itself at the time you get the drug. So you get the chemotherapy injected into you. It basically lasts in your body for a few hours, but it kills any rapidly reproducing cell. And the way it does that is it interferes with the cell reproduction cycle. So it's going to also kill your normal cells. And that's why chemotherapy has such a bad side effect, is it kills normal cells like healthy normal tissues, as well as cancer. Basically, it's like carpet bombing. It kills everything. Whereas targeted therapies that we're talking about that have been the mainstay of cancer development since 2005 are all for specific mutations. So we treat cancer now by the mutations, not necessarily by the location of the tumor. So it's all, if you have this gene and this gene and this gene mutated, then you get this combination of drugs. If you don't do the genetic testing, you'll never know which combination of drugs are going to be best for you.
Yeah. And lastly, we have inherited mutations. As Alex mentioned earlier, these are things that either mom or dad or both of them passed on to you unwittingly, and typically lead to you being a little more sensitive or a little more predisposed to certain types of cancer. If you're 50 plus when you first get cancer, then if you have an inherited mutation, it's not driving the cancer, it's just kind of helping it along a little bit or preventing your body from responding as well as it could. If you're 50 years and younger, we often start from a place of assuming there's an inherited mutation involved. And there's an excellent test, blood-based test that looks at 127 known commonly inherited mutations that are associated with cancer. So that's a very important one for you to know, because it can influence your treatment significantly, and also for other family members to know, because there are lots of things you can do to prevent cancer, even if you have these inherited mutations. So it's valuable information.
Yeah, everyone should get an inherited mutation panel at birth. Everyone should.
Yes.
Seriously, it's a cheap test and it would save a lot of money and a lot of lives, because then we would be able to determine someone's risk factor of them getting cancers and be able to say, okay, well, we know you have a higher risk of breast cancer, so let's monitor you a little more than we normally would, and let's do regular MRIs or something, and then we can catch it at a very young age. And also that person can then knowledgeably reduce certain behaviors that would put them at higher risk of cancers.
Yeah, almost certainly that is the way of things, but it'll be a little while probably. This little statistic, I just wanted you folks to know, because I think it's really so hopeful. And I think when you're seeing some of the statistics that you've seen for pancreatic and bile duct cancers, it's important, I think, to have reason to be hopeful. So right now, there are 100,000 clinical trials for cancer in the world. And right now, clinical trials are actually quite easily accessible once you've had the genetic testing to show what mutations you have and that you're fit for the trial. You don't necessarily, and very rarely, in fact, have to travel to take part in the trial. So clinical trials have really changed this last 10 years as the pharmaceutical companies are trying to design these very targeted therapies. So I just wanted you to keep that in mind. If you've got ideas of clinical trials being very experimental or really inconvenient and all that stuff, or hard to get into, once you have the genetic and molecular data to show that you're fit for the trial, it's actually kind of like a hop, skip, and a jump, assuming you're fit. And there are many of them. And this 100,000 clinical trial number also means that these are specific to new treatments and combinations of treatments. And in a very short period of time, many of those 100,000 clinical trials will be wrapping up. There will be summary, and there will be FDA and Health Canada approved treatments or combinations of treatments. As Alex said, as like every week, there are new treatment options. And that's what's so important to really know about cancer, is that even if some of the statistics of some of the treatments that you or your loved one might be on right now say, okay, it's going to add an extra 2 years to your life, that doesn't mean that's all you have, because next month something new could be coming out that's going to add another 5, and give you lots more quality time, or even be curative. So we've seen it all, haven't we, Alex?
Yeah. So, in short, precision oncology is basically turning cancer from an acute deadly disease into a chronic disease that we can just treat constantly with different drugs.
Yeah, like a high blood pressure or a
Exactly.
diabetes or something like that is where it's headed for a lot of folks. So.
Yeah, definitely.
And I wanted to just add this little statistic here about the biopsy handling. I was mentioning the pathology earlier. Um, we're really trying to make a point how important enhancing your diagnosis is, because it gives you and your oncologist so many more options. It's just the most important thing you could do for yourself. But there's a couple of key variables that matter, and the types of tests you get, which we've talked about, are one of them, but also how your biopsy sample is handled and how it is treated for testing is really critical. Right now, because the technology is kind of a mishmash right now, I call it the Wild West, because it's so new, and there's very little consensus about really how to go ahead in public cancer to apply these tools. So different doctors in different hospitals and different pathology labs will have very different ideas about this right now. But one of the biggest problems that we have is that when a biopsy sample is taken from your body, the way that it is handled by the surgeon and at the pathology lab, which is perfectly fine for standard pathology, often leads to a highly degraded sample that doesn't allow for very good quality genetic testing. In fact, more than 40% of the time, regardless of which of those 7,000 tests you're using, more than 40% of the time, the sample is so compromised that the test can't be run properly, or you get a very limited amount of data. So there's a new technology that allows us to reduce that 40% to practically nothing and almost guarantee an excellent result. But again, it's not part of public health care. And it's something that you kind of have to know exists in order to go looking for it, because it's so new, literally this last year. But again, that's my intention in telling you that, is not to overwhelm you, but to give you hope that there's so many ways to make this work. There's so many options for enhancing the quality of your diagnosis and therefore the quality of the treatment that you're receiving, and ultimately your outcome and how long you live and what side effects or symptoms you experience during treatment. So there's always a way through and around, and that's really why we're here, is to help you find it. So this is a little more information about the biopsy, that really using this new technique, you get a highly purified sample, and then we're able to make sure that you get a result every time. The last thing you want to do is have to have another biopsy or lose the opportunity to get this data that we've just gone on about how important it is. So. And pillar two is personalized research. So if the first one is get that diagnosis as thorough and accurate as you possibly can using PET-CT and genetic and molecular testing. Now that we've done that, we need to take all that information and everything that's known about you and your cancer and your case, and everything that's out there right now about that, all the latest, most current approved treatments, and put it all together so that it can be applied for you. And so that's where the personalized research is. Our team usually takes 20 to 30 hours of their time. The standard clinical oncologist takes about 15 minutes with you to discuss what your options are. There's not a lot of personalization possible for them given what's expected of them. But there's a big difference, and you get a really highly accurate and thorough treatment plan when you add that personalized research.
Yeah, and I think there's a good point you put there, Michelle.
Yeah.
Well, of course, you want to only be using FDA-approved drugs. That's very important. They've been rigorously tested. But I think what the important thing here is this research is a very important aspect, because there may be 5 or 6 different drugs for your mutation. So if you have, let's say, a EGFR mutation, there could be about 3 or 4 different companies making a drug that targets your mutation. How do you know which one is best? Well, that's where the personalized research comes in. So then you have to look into the clinical trials and say, well, this drug over here worked better in patients with my mutation that had this cancer, but over here, this drug here worked much better in patients with my cancer than this one. And so, you have to really look into the personalized aspect of which drug that is targeting your specific mutations is the best for you.
Yeah, I guess the point we're really trying to make is that until very recently, it would be appropriate to think, what's the point? There's only one or two types of treatment anyway. It's chemo
Yeah,
or radiation or both.
exactly.
And
Yeah.
we're really trying to drill home the concept that there are literally hundreds of treatment options right now that are
Thousands.
better than standard chemo and radiation if you just know which ones are right for you.
Exactly.
So Alex, we're going to talk just briefly about targeted therapy and immunotherapy, what they are, and then get into specific targeted and immunotherapy options for these types of cancers we're here for today.
Great.
So tell us a bit about targeted therapies.
Yeah, so targeted therapies are, as they say, a drug that will target a specific genetic mutation. So if you have a PIK3CA mutation, that is a oncogene, and it is a mutation that causes the oncogene to stay turned on permanently, causing the cells to grow and copy themselves. There's a drug called alpelisib that targets any cell in the body with that mutation. So that's what a targeted therapy is versus a chemotherapy drug that kills any cells that happen to be reproducing. This is why we're discussing the mechanisms of what causes cancer, because you have to target the mechanisms with a drug that targets that mechanism. So a targeted therapy is a drug that targets a specific mutation in a certain cell. So if you don't have a PIK3CA mutation, alpelisib is not going to help you. It's not going to do anything for you. But if you have a PIK3CA mutation in your tumors, it's going to be a life-saving drug. So knowing what mutations you have should be the very first thing you do before you start any treatment. And that's true for chemotherapy drugs. Certain mutations will allow certain chemotherapy drugs to work better. Other mutations will prevent those chemotherapy drugs from working. So if you can go to the next slide.
Sure.
Yeah, so I like this statistic for pancreatic cancers. For patients who are able to go on treatment that aligns with their tumor biology, in other words, patients that have done molecular analysis, typically live at least on average a year longer. And that's pretty important. That's almost a doubling of the standard. But we typically see survival times longer than that, much longer than that, when patients get the right drug for them.
Yeah.
Next slide. So off-label drugs. What's an off-label drug? Basically, an off-label drug is a drug that is used in one type of cancer, but hasn't been approved for another type of cancer. So alpelisib, the drug I just mentioned that targets PIK3CA mutations, is approved right now for breast cancers. However, it also works in colorectal cancers. And it also works in other cancers that have a PIK3CA mutation. However, it's not approved in those other cancers. So using alpelisib in a colorectal cancer is what we call off-label treatment. It's an FDA-approved drug, but it's approved for breast cancers, not approved yet for colorectal cancers. It will be someday, obviously, but the way drug makers get their drugs approved is they typically, it's such an expensive process. It's about $1.5 billion to get a drug approved to market. So any drug maker who spent a lot of money on this drug, they're going to try to find a cancer that has the most amount of the mutations that they target. So in this particular case, the drug makers of alpelisib said, well, out of all of the cancers we can see, breast cancer has the most amount of PIK3CA mutations. So we will have our drug approved for breast cancer because that allows us to sell as much of the drug as possible. If they had it approved for colorectal cancers or pancreatic cancers, then they would see a much smaller sale of their drug because much fewer patients have that mutation. So that's just how these things are done. Okay. Next slide.
Then just a little bit about immunotherapy before we start talking about these things specifically.
Yeah. So immunotherapy, basically, there are about 12 to 14 different pathways that tumor cells hijack the immune system. And tumor cells and immune cells have a lot in common. They both love sugars. They both can grow rapidly. And they both use the same growth factors and hormones and different things. So for a cancer, getting the immune system to come to the tumor and then turning it off is really a benefit. And they do this with about 14 different pathways. One of those pathways is called the programmed death 1, also known as PD-1. And basically what it is if you have a cell in the body that does not have PD-1 protein on the outside of it, your immune system will kill it. So you have to have PD-1 on every cell or your immune system will attack it and kill it. And I'm talking in a very general way, a really basic way here. So what happens is when a tumor is growing really fast, the immune system is going to move in to investigate it. It's going to send T cells and say, okay, this shouldn't be happening in this tissue. It's growing too fast. Go kill those cells that are growing too fast. So the T cells will go in there and the macrophages will go in there and the natural killer cells will go in there and they'll go in there to try to shut this down. And then what happens is the tumor cells produce a massive amount of this PD-1 protein. So it creates this protective bubble around the tumor. And so these immune cells come in and say, oh, no, it's a normal cell. It's got high PD-1. We should just leave it alone. And so then the immune system will just actually stop right there. And it's like turning the switch off on the immune system. And then the cancers are able to utilize all of the proteins and growth factors that the immune cells naturally produce for each other. And what a PD-1 inhibitor is it's a drug that inhibits this bubble of PD-1. It acts like a sponge. It soaks up this extra PD-1. And I'm talking more not in a molecular way. I'm just trying to give you a descriptive idea of how this works. So, kind of envision the tumor as being surrounded by this PD-1, the immune system going in, seeing the PD-1 and thinking that it's a normal cell structure. And then the PD-1 inhibitor acting as a sponge to soak up this free-flowing immune or PD-1 that's surrounding the tumor. And now all of a sudden, the tumor is uncloaked and the T cells that are in the tumor microenvironment can go, aha, you're a tumor. We're going to kill you now. And they do. And they start rapidly expanding. So PD-1 inhibitors can create cures in cancers. We've had numerous patients who've had literally months to live. And we found out that they had high T cells in their tumors and high PD-1 expression and a lot of mutations. And therefore, these PD-1 inhibitors, as soon as the patient's got the PD-1 inhibitors, they wiped out the tumors and the patients are completely cancer-free, regardless of the type of cancer.
Yeah.
So next slide.
Yeah, well, I just kind of did all that.
Okay.
Yeah, but that's okay.
So
it's all in the PDF. People can read it all later.
So as I mentioned, it's about 14 different pathways. We now have drugs for we have two main pathways, the CTLA-4 and the PD-1 pathway. We have drugs for both of those pathways in Canada. A lot of drug companies make drugs for PD-1. A few companies make drugs for CTLA pathways. And now we've got LAG-3, which is another pathway. And there's a EDO, which is another pathway. So there's a bunch of different, pretty soon we're going to have drugs for all of these pathways. And, not every tumor can be affected by the PD-1 pathway or the CTLA-4 pathway. So a big part of what we do is we find out if your tumor is using PD-1 or CTLA-4 or, EDO to hide from the immune system. And if it is, then we can target it. And there are a few indications that we can do through tumor testing and through RNA sequence testing, expression testing, that we can say, hey, yes, you've won the lottery. This happened just recently. We had a patient with an endometrial cancer. The oncologist said, hey, listen, you're done. The drugs are not, the chemotherapy is not affecting you. She called us up and said, hey, can I get this tumor DNA sequencing? We did that. We found out she had something called high tumor mutation burden. In other words, she had a lot of mutations and high PD-1 expression. And so we knew right away that that patient would respond well to immune therapy. So we convinced the doctor to prescribe it. The patient had to pay for it out of pocket, and immediately their tumor started shrinking. So, at that point in time, the doctor was saying, hey, check into palliative care. You've only got a few months to go. And now this patient is back to living her full life. And she's only been on the drug for about 5 or 6 months. We see this all the time. So definitely very important to determine whether immune therapy is an option for you or not. And it doesn't matter what type of cancer it is, it's specific to the molecular features of your cancer.
I'd like to just add to the comment you made about pay out of pocket. Where there's a will, there's a way, folks. With this particular person, and this is not uncommon, we were able to arrange compassionate access. So they got a few treatments at a greatly reduced cost. And because of the benefit that this patient demonstrated with just a few treatments, the public healthcare system actually stepped in and has now offered to pay for the treatment for her.
Actually, it's a drug company.
Oh, sorry, the drug company.
But it was a public health oncologist that really lobbied the drug company to provide the drug for free.
Yeah, and that was after they argued that the person shouldn't even bother getting the testing, right? So that's another key point, is that a lot of times oncologists, I mean, they really believe that what they're doing is the best possible thing for you. They're not trying to be harmful or deceptive. They just don't have access to all of the information. So once you present them with that information, then they can actually pick up the ball and run with it. And most will quite happily, and they're willing to get on board, even if previously they were telling you to prepare, get your affairs in order and palliative chemo is all we have to offer. Your oncologist really is on your side and wants the best for you. And you just right now in cancer care, you kind of have to help them out by assisting with some of these diagnostics that aren't available right now as part of public health care.
Especially in Canada. These tests are commonly used in other countries like the States and Europe, but Canada's pretty behind on that.
And Australia.
As you mentioned, 23rd, wasn't it? 23rd?
Yeah, 23rd out of 28 is Canada.
So there you go.
Yeah, Australia's a real leader, in terms of countries that have like the best cancer centers of all the world. Australia has 5.
Mm-hmm.
5 out of 20 are there. About another 5 out of 20 are in the US, and the rest are kind of scattered around. Princess Margaret in Canada is the only one in Canada that's on the list. But just another statistic that may be of interest to you. All right, now let's get to the part that you're really here for. Aside from, okay, what do I need to know in order to make sure I'm getting the best care? I hope we've gone on enough about how important enhancing your diagnostics are. But now Alex is going to run through a list of some treatments for both pancreatic and bile duct cancers, and talk about their statistics for you and how to access them.
Yeah. So the statistics we're going to be using here are standard cancer statistics. There's 3 that we need to look at. And the first one is called overall response rate. And basically that is how many patients out of 100 actually get a response to the drug. So let's say you have pancreatic cancer, there's 100 patients in the trial and 60 respond to the drug. Then your overall response rate or your response rate is 60%. Very important statistic. The next statistic is the progression-free survival. And this is what we call a median. And so basically what it is let's say you have 100 patients in the trial with pancreatic cancer and you go on the drug, 60% of those patients get a response. That's great. But after 6 months or 8 months, then 50% of those patients have their cancer returned. Then what happens is the doctors and the scientists will mark that date on the calendar and they'll say at 8.5 months or, however many weeks, 50% of the patients had their cancer return. So it's not all of the patients, this is 50%. It's called a median. So the median is 50% right in the middle halfway. So the other 50% of the patients haven't had their cancer return yet. Only 50% have. They call that the progression-free survival. And then when 50% of the patients in the trial die, they call that time period the overall survival. So we've got response rate, how many patients out of 100 respond, the progression-free survival, the time where 50% of the patients in the trial have their cancer return, and then the overall survival, where 50% of the patients in the trial die. Okay, so standard chemo, FOLFIRINOX. There's a few different protocols for this. And you would say, well, which one is best? Well, most doctors will just randomly pick the one they like the best. I see this a lot. So standard first-line chemo for pancreatic cancer is FOLFIRINOX. Now, what is best? the doctors will tell you that it's pretty well the same. Well, there's a study that actually can tell you which is best. So they did this study. They compared 6 months of FOLFIRINOX, or they compared to 4 months of FOLFIRINOX followed by 5-fluorouracil. So 5-fluorouracil is the F in FOLFIRINOX. It's a drug that's been around for a long time. It's a derivative of mustard gas. And it works, it's used in a lot of cancers, they call it a 5-FU. So in this study, what they did was they gave 4 months of FOLFIRINOX, and then they followed up with just 5-FU by itself. It's called 5-FU maintenance. Or you could get what's called sequential treatment with FOLFIRI-3, which is a different combination of drugs, followed by 2 months of gemcitabine. So, I see these being used randomly. So which one is best? Well, let's look at the data. So the progression-free survival, once again, the point at where 6 months or 50% of the patients have had their cancer return. So the progression-free survival at 6 months was 47.1% in the FOLFIRINOX group. It was 42% or 42.9% in the FOLFIRINOX plus the 5-FU maintenance, and only 34.1% in the sequential FOLFIRI gemcitabine group. So as you can see, the first two are not equivalent as far as the third one in regards to progression-free survival. So, they're not all equal. More importantly, the overall survival was significant too. So the overall survival for the FOLFIRINOX group was 10.1 months, but it was 11.2 months in the maintenance group. So while the maintenance group had their cancer come back sooner, slightly sooner, or more of the patients had their cancer come back sooner, they lived longer. And then it was only 7.3 for the sequential group. So it really looks like, having FOLFIRI 3 plus gemcitabine is not the way to go. And then they looked at what's called the median survival without deterioration of quality life. In other words, how happy were these patients taking this chemotherapy? And they found that the FOLFIRINOX group, after 7.2 months, the patients were like, okay, this chemo is really starting to affect me. Whereas with the maintenance group, it was 11.4 months before the patient said, okay, the chemo is starting to affect me. However, it was only 7.5 months in the sequential group. So, you have to look at these details. And to me, you do not want to take FOLFIRI followed by gemcitabine. It's not an equal protocol in any of these conditions. And the maintenance, where you do the initial FOLFIRINOX and then follow up with 5-FU seems to be better in many ways. Definitely survival's longer, and the quality of life survival is much longer. So definitely, if you have standard adenocarcinoma pancreatic cancer, go for FOLFIRINOX plus maintenance 5-FU. Next slide. So PARP inhibitors, we're getting into targeted therapies now. PARP is a process involved with DNA repair. And if you have mutations in certain genes, such as the BRCA1 and 2 that I'm sure you've heard of before, or a drug called PALB2, or sorry, a gene called PALB2 or ATM, these are all tumor suppressor genes. And if they're damaged, if they have these germline mutations, inherited mutations, then they cause a problem and you get this pancreatic cancer at an earlier age. But it also creates this Achilles heel in the tumors. And this Achilles heel is referred to as homologous repair deficiency. So if you normally have a cancer, it's going to be able to repair its mutations and be able to grow properly. In this particular case, these tumors can't repair their mutations properly through one of the pathways called the HRD pathway, homologous repair pathway. So they have this HRD, this homologous repair deficiency, and they accumulate a lot of mutations, which causes a lot of the cells to die. So one of the drugs used in standard care is called oxaliplatin. It's a platinum drug. And so if you have PARP, if you have any of these mutations in BRCA1 or PALB2 or ATM, or a bunch of other genes involved in this pathway, then you're going to get an extra benefit from the platinum drugs. That's the O in the FOLFIRINOX. So in other words, if you have this, you're going to get a much better response to FOLFIRINOX than the other patients. So you'll be one of those 50% patients where the disease didn't come back within the first 8 months or so, or you had a longer survival, maybe a 2-year survival rather than 11.4 months survival. So patients with first-line FOLFIRINOX and just cisplatin and gemcitabine get something called maintenance olaparib. And olaparib is a PARP inhibitor. It inhibits this PARP pathway that is deficient in these cancers. It's not going to benefit you if you don't have mutations in this pathway. But if you do have mutations in this pathway, then this combination of drugs is going to give you a much better result than it would to somebody who didn't. And the way to determine whether you have mutations in this pathway, once again, is tumor DNA sequencing. Next slide. So here's a couple examples of PARP inhibitors. Here's a drug called rucaparib, another PARP inhibitor. And so in this particular case, patients had either BRCA or PALB2 mutations. Their progression-free survival was 13.2 months. That's longer than the overall survival of the average patient getting standard care. So, and the overall survival for these patients was 23.5 months. So if you have pancreatic cancer and you're under 50, there's a really good chance you have homologous deficient disease, and that maintenance rucaparib or olaparib is going to provide you a significantly longer survival. So definitely get genetic sequencing. Another mutation here, it's called the KRAS gene. Most adenocarcinomas, most pancreatic adenocarcinomas have a KRAS mutation. It's one of the first mutations to occur. It's a driving mutation. But if you have a certain type of KRAS mutation called the KRAS G12C, and basically what that is you have a G amino acid. So all amino acids are designated by a letter, an alphabet letter. In this particular one, it's guanine, and the C refers to cytosine. So what has happened in this person's cancer is they have, in their KRAS gene, they're supposed to have a G at the 12th position, but they have a mutation that's actually replaced that G amino acid with a C amino acid. And so that occurs into a small percentage of pancreatic cancer patients, that specific mutation. But if they do have that, then there's a class of drugs that target that specific mutation. And there's 2 drugs available now. They're relatively new. One drug is called adagrasib, and the other is called sotorasib. So you want to know if you have this particular mutation or not, because these drugs will provide you with extended survival. Next slide. So other mutations that we look at. So we're starting to see now that 20 to 30% of pancreatic cancers have potential targetable driver mutations. So we refer to these as fusion mutations. Now you probably recall fusion mutations from about half an hour ago when we discussed it. That is where the activation component of a gene that's supposed to be turned on all the time gets attached to a oncogene that's supposed to be turned off, and prematurely turns it on and has it turned on. So it's like having a faulty light switch to the gene. So NRG, NTRK, ROS1, ALK, FGFR, and RET are just some examples of genes that are supposed to be turned off. They're not supposed to be turned on. They're only turned on very briefly for short periods of time. And when they do get turned on for a long period of time, they cause cancer. So there are drugs that target NRG1. There are drugs that target NTRK 1, 2, 3. There's drugs that target ROS1. There's drugs that target ALK. There's drugs that target FGFR. There's drugs that target RET. ALK is a perfect example. There's a ton of ALK inhibitors. There's about 6 or 7 of them available now in Canada. And it doesn't matter what kind of cancer you have. If you have overexpression of ALK or mutations in ALK, then ALK inhibitors are going to be really beneficial for you. So ALK is something that is only expressed, it's only turned on when you're in your embryonic state. So once you're an adult and fully grown, you shouldn't have any ALK overexpression. You should not see any ALK in your body. So if you do find ALK mutations or high expression of ALK in your tumors, then you know that that is a driving factor for the tumor. And if you give that patient, regardless of the type of cancer, if you give that patient that particular drug that targets ALK overexpression, and there's like 6 or 7 of them, then that patient is going to respond to it, regardless of the type of cancer they have. So the other thing is, because ALK is not expressed in anything else but the tumor, these drugs have hardly any side effects. So if ALK was normally expressed in your brain or your heart or your lungs or something like that, and you got an ALK inhibitor, then it would affect those organs in some manner. You would have side effects from it, like you would from chemotherapy. But because ALK is not expressed in adults, it's only expressed in the tumor in certain people, then giving a drug that targets it is going to have really no side effects, or very minimal side effects. So that is an important consideration when you look at targeted therapies. So a brief example, there's a patient with pancreatic cancer. They'd been heavily pretreated. They were at the end of their road. They'd had all kinds of chemotherapy. They did sequencing. They found that they had this fusion of 2 genes. One gene is called RDX. The other one's called MET. MET is another gene that you can target. And so they gave this patient crizotinib, which targets MET overexpression, also targets ALK overexpression. They gave this drug crizotinib, and the patient is still alive and cancer-free more than 1 year on therapy. That patient would be dead by now otherwise. So next slide. So a little example, NRG1 alterations. So because there was the finding that 20 to 30% of patients have NRG1 alterations, one of the big pharma companies said, great, that's enough to make a drug to target. So they created this drug called zenocutuzumab. I don't know where they come up with these names from. This drug basically inhibits the NRG1 pathway. The way it works is it binds to 2 genes. One's called HER2, the other is called HER3. These 2 genes are common in breast cancer. HER2 overexpression is a type of breast cancer called HER2 positive breast cancer. But they found that this interaction was created with HER3 and NRG1. So they thought, okay, well, let's get a drug that blocks NRG1 and it will interfere with this whole pathway. So, and sure enough, it did. And so the FDA approved this drug in 2020. So it's around right now. So if you have pancreatic cancer and you have not been tested for NRG1, you're missing out on a great opportunity, because it's an FDA approved drug that will target this pathway in your cancer. So definitely find out if you have NRG1 overexpression, fusions, or mutations. So another example was a patient that had a 52-year-old male that had a ATP1B1 NRG fusion, and he had a partial response after receiving treatment for at least 7 months. Now please note that these patients are heavily pretreated patients. They have no other treatment options for them. Chemotherapy stopped working on them. They probably had cancer for a few years. So another 7 months, receiving benefit for 7 months or a year is something that, can buy them time and quality time too on these drugs. It's not as if you're like on a chemo drug. You're not getting wiped out. You're having a targeted therapy. It's going to have a minimal amount of side effects. Another example, 34-year-old male with an ATP1B1 NRG fusion achieved a stable disease for at least 7 months. So, these are significant. So next slide, please. So as I mentioned earlier, there's, one of the problems with pancreatic cancer is a stroma that protects them, and the breakdown of the blood vessels. So you can't get the drugs, chemotherapy drugs and so on, into the tumors properly. They have all these other cells interfering with the process. So this particular drug, devimistat, was combined with the standard care, FOLFIRINOX. And it was in patients that were, fairly heavily pretreated. And so what they did was they combined this, and they found that the overall response rate was 61%, which is really significant compared to FOLFIRINOX by itself. Additionally, at least 50% of these patients lived to 19.9 months. And of course, the other 50% were probably lived longer. But the average was 19.9 months, which is much better than FOLFIRINOX by itself. And the progression-free survival was 9.9 months. So just adding this significantly improved the survival. More importantly, if you look at the standard care, the overall response rate for FOLFIRINOX is typically 31.6% versus 24% with standard gemcitabine plus nab-paclitaxel. So, both of these standard care treatments, FOLFIRINOX by itself is only half of the patients that respond to the combination of devimistat plus FOLFIRINOX. It's almost doubling the standard and almost tripling the standard of gemcitabine plus nab-paclitaxel. So 61%, much better than 31.6 or 24%. So FDA has granted approval for this drug. So definitely something I would be looking into getting if I was, dealing with this sort of issue. Next slide. So immune therapy. So typically immune therapy doesn't work very well in pancreatic cancers unless they have high tumor mutation burden or other things that stimulate the immune system. So in patients that just had standard run-of-the-mill adenocarcinoma, they didn't have the indication for immune therapy, which is high tumor mutation burden. They gave them a combination of the immune therapy, pembrolizumab, plus radiation therapy, plus a drug called trametinib. Which is, I believe, a MEK inhibitor. So it targets a pathway called the MEK pathway. And they compared that to just radiation plus gemcitabine. And this was in locally recurrent resected pancreatic cancer. So these patients were the 20% that had surgery, but their cancer came back, sometime later. So in this particular group, when they combined the immune therapy plus the MEK inhibitor plus radiation, the overall survival was significant. So the overall survival in that group was 24.9 versus only 22.4 months. But more importantly, the 2-year survival rate with the combination was 56.5%. So almost 60% of the patients on this triplet therapy were alive 2 years later versus only 37.6 for the standard radiation plus gemcitabine. So, that's something you can do without actually having to do genetic testing. Next slide. So we're going to go into cholangiocarcinoma now. So first line treatment with advanced intrahepatic cholangiocarcinoma, typically gemcitabine plus cisplatin. The average survival, medium survival, which is 50% of the patients, is typically 1 year. Second line. So if you live beyond that, and your cancer comes back and they want to give you a second line of chemotherapy, which is going to be a different type of chemotherapy typically, the overall survival is 6.2 months. And more importantly, only 5% of the patients will get that 6.2 months. So the response rate after you've had your first line of chemotherapy is pretty dismal, 5%. So let's go on to the next slide. So once again, if you have this KRAS mutation, which is common in pancreatic cancers, then it determines what your prognosis is with standard care. So this study looked at how well people with certain types of KRAS mutations survived, if they did better or worse. And they found that when they had a G12 type of KRAS mutation, that was the worst prognosis, even after curative surgery. So, these patients had this mutation. They were told that, hey, your surgery is going to cure you. But meanwhile, they had this KRAS mutation that wasn't looked at until afterwards. And then, they were quite surprised when their disease came back. Had they known and done genetic testing and known that they had this KRAS mutation that created poor survival, they would know that this curative surgery wasn't going to be curative, and they had to look at other options. Important information. So the study found that patients that had the G12V, so that would be a guanine being replaced at the 12th position by a valine, had the worst outcome. And they found that patients with KRAS mutations had on average an overall survival with standard care of 11.3 months versus 29.1 months if you didn't have those mutations.
Oh.
So, disease-free survival, which is like progression-free survival, was 9.3 months versus 20.9 months in those with G12 versus non-G12 variants. So once again, what this tells you is that just because you have a KRAS mutation doesn't mean you have a worse prognosis. It's the type of KRAS mutation you have. So very important to do that precision oncology to understand, do you have a bad KRAS mutation or do you have a good one? So if you have a KRAS mutation that is not a G12 subtype, then you can have a 29, 30-month survival with standard care. If you have the G12 variant, then you want to be looking for different treatment options than the standard care. So the median overall survival, 28.9 months, disease-free survival, 16.2 months in patients with wild type. That means no mutation. So not having a mutation in KRAS or having a mutation that is not a G12 type means that you can have a much longer survival with standard care. So very important to get genetic tested, find out what mutation you have. Next slide. So targeting mutations in cholangiocarcinoma, up to 50% of intrahepatic cholangiocarcinomas are different. There's a lot of variation. It's called molecular heterogeneous, but up to 50% of them have unique targetable mutations. So some of the drugs we mentioned before, everyone's going to be different, but 13 to 14% of these patients have what we call FGFR2 fusions. FGFR2 is one of these, so fibroblast growth factor receptor 2. Fibroblasts are cells that are in the tumor microenvironment of pancreatic cancers, and we believe they contribute to the growth of pancreatic cancers. So if you have a fusion in this gene, the FGFR2 gene, or a rearrangement or mutation of some sort, then you have FGFR mutated cholangiocarcinoma. So there's actually 3 new drugs approved by the FDA. So the first one that was approved by FDA is called pemigatinib. So once again, if you have an FGFR2 alteration, then this drug is going to be very beneficial for you. So the first drug that was approved by the FDA a few years ago, it was approved for refractory advanced cholangiocarcinoma. So in other words, patients that have already been treated. Now, if you recall, the second line chemotherapy typically only gets a 6.2-month survival in 5% of the patients, 5%. So in pemigatinib, 35.5% of the patients actually responded to this drug as a second line treatment. So much better than the 5% offered by chemotherapy. Next slide. Another one of these drugs that is FDA approved is called infigratinib. It's got accelerated FDA approval. So at a median follow-up of 17.1 months, the overall response rate was 41.7, which is really good. The disease control rate, in other words, how much it controlled the disease, is 82.5. That's a significant benefit. So what the disease control rate is it's a combination of what we call the RECIST criteria response rates. So the types of responses you can have are called a complete response, where all of the tumors shrink. You can have a partial response, where some of the tumors shrink and others don't. You can have stable disease, where the tumors don't shrink, but they don't grow. Or you can have progressive disease. And progressive disease is a negative response. It means you didn't respond and your tumors are still growing regardless of the drug. So the disease control rate is a combination of the 3 positive responses. So it is the percentage of patients that had a complete response, plus the percentage of patients that have partial response, plus the percentage of patients that have a stable disease. So 82.5% of those patients were able to have either a stable disease or a partial response or a complete response. More importantly, 95% had documented tumor shrinkage. So great drug if you have this FGFR alteration. So next slide. And finally, there's futibatinib. So this is another company that's developing a FGFR inhibitor. More importantly, this drug works a little differently. It targets all 4 subtypes of FGFR, so not just FGFR2. So the other drugs were specific for FGFR2. This targets FGFR1, FGFR2, FGFR3, or FGFR4. So if you have a mutation in any of those FGFR receptors, not just FGFR2, then this is the drug to take. And so it works a little differently. It irreversibly binds this mutation. So it works quite well in previously treated cholangiocarcinomas. Once again, previously treated patients only have a 5% chance of responding to chemotherapy. This has a unique action. So it binds to a different kinase domain than the other 2 FGFR inhibitors we just spoke. You don't need to know the details of that, but it's just different from those 2. So basically what these companies do is one company will create the drug will work great, and another company will come along and improve the drug, and then another company will come along and improve that company's drug, and you just get this progression of these ever improving drugs for a targeted therapy. So in this case, futibatinib is the 3rd generation of the drug, and it works really well. Importantly, responses with this drug are independent of age, of sex, and the number of prior therapies. So patients that may have had 3 or 4 different types of chemotherapy responded to this drug. In fact, even patients with a worse prognosis, like those KRAS mutations that create a horrendous prognosis, even those patients had a significant response to futibatinib. And in this particular case, once again, these are patients that have already been treated heavily, so they should only have a 5% chance of responding. And if they did respond, they would get a maximum of 6 months. In this particular case, the median overall survival was 21.7 months, and the 12-month overall survival was 72%. So this is really knocking it out of the park. Definitely a great reason to get tumor DNA sequencing and expression testing to see if you have markers that will determine whether these drugs are going to benefit you or not. Next slide. So IDH1 mutations, these were first discovered in a type of brain cancer called gliomas, and they indicate whether certain combinations of drugs will work in those patients. So recently we found that IDH1 mutations also happen in pancreatic and cholangiocarcinomas. So in this particular case, this was in patients that had mutations in IDH1, a gene, and this was called the CLARI-DH-HY trial. And so the maximum treatment duration with this drug, it's called ivosidenib versus a placebo. So the duration of responses was 34.4 months, fairly significant, compared to only 6.9 months with the standard care. The standard care was the placebo. So the standard care is often used as a placebo. So medium treatment durations were 2.8 months and 1.6 months. So the medium overall survival was 10.3 months in the ivosidenib group versus 7.5 months when it high is 11.1 months in the placebo group, 12.4. So the important thing here to understand is that at least 50% of the patients lived to 10.3 months, but obviously some of those patients were living at 34.4 months. So next slide. Yeah, so I think we missed a slide here. I believe there was another IDH1 targeted drug available. So we'll have to skip that for now. But there are probably going to be about 3 or 4 of these drugs within the next few months. So definitely it's FDA approved. If you have IDH1 mutations, definitely this would be a drug of choice. So treatment monitoring, very important to understand whether you're responding to a treatment. The standard care procedure is to take a CT scan and measure the size of the tumor, and then go back in 4 months and take another CT scan and remeasure it. Problem is if you're not on the right drug, then by the time you've had that 4 months, your tumors are going to be all over your body. And then you're in a whole different state. Then you're completely untreatable. There's all kinds of problems. So you don't want to have to wait. You want to know in real time, is that drug working now or is it not working now? And a CT scan and measuring the size of your tumor is one of the most ridiculous ways of determining whether treatment is working or not. It really is old school. It's sad that it's still being done that way, but that's the reality of the situation. So there is a better tool. Can you go on? This is called liquid biopsy. So let's say you have a KRAS mutation. There's no way of determining whether you're responding to a drug or not. But what we can do is we can actually measure the amount of that KRAS mutation in your blood. So basically, tumor cells release their DNA when they're metastasizing. They release their DNA and their RNA and their proteins in things called exosomes. These are like little bubbles of damaged DNA that the tumor cell is being driven by, and they spread these into the blood, and these exosomes travel throughout the body. They're in urine, they're in spinal fluid, they're in blood, they're in sweat, they're in everything. And they can actually get taken up by normal cells and convert normal cells into tumor cells just by these exosomes. So obviously, when you're in a metastatic state, you're going to have a lot of these exosomes in your body, and those exosomes that are in your body are going to be containing the mutations that are known to cause your cancer. So if you have a KRAS mutation and you want to try a certain drug, let's say you want to try one of these FGFR inhibitors, or you just want to know if your chemotherapy is working, what we can do is we can take a sample of your blood, we can measure the amount of your KRAS mutation. Let's say it's 8% before you start treatment, then we measure it again about 2 weeks later, and it's down to 2%, and we could say, hey, it's working. The drug is greatly reducing the amount of these exosomes in your blood. Your tumor is having a hard time metastasizing. We know the treatment is working. Let's say it doesn't go down. Let's say it's 8% and it stays the same 2 weeks later. Then we know that the treatment's not working and it's time to switch you on a drug. So you don't have to wait 4 months. You can tell right away, within 2 weeks, whether your treatment is working or not. Next slide, please. More important, this has been an amazing tool for us for determining whether people are responding to immune therapy. So in immune therapy, when you get a PD-1 inhibitor, as I mentioned previously, what happens is you have all of these T cells and macrophages and other cells, you have them inside of the tumor microenvironment, but they're turned off. The tumor has used a PD-1 pathway or a CTLA pathway, CTLA4 pathway, or the EDO pathway, or the LAG3 pathway, or one of these other 14 pathways to turn the tumors off like a light switch. So what can happen in immune therapy when it works? What happens is these immune cells start expanding within the tumor. So in other words, they are shipping in all of these immune cells into the tumor. And so what happens is the tumor is going to get much bigger when you look at it through imaging. And so one of the biggest problems with the immune therapy studies, and we've been using immune therapies for 6 years. We were the first company ever in Canada to use immune therapy. The patient that got the first immune therapy is alive today. They had 4 treatments, 4 injections of a PD-1 inhibitor and a CTLA4 inhibitor, and they're still alive today, completely cancer-free. It wiped out all of their tumors. So pseudoprogression is when the tumors look bigger than they're supposed to. And more importantly, what can happen is you can have these tiny little tumors that are too small to be seen on imaging. So imaging has a hard time, like CT scans, PET CTs, X-rays, they have a hard time detecting tumors that are smaller than 2 or 3 millimeters. So they just don't see them. So in immune therapy, what can happen is if you have a bunch of immune cells that are inside that 3 millimeter tumor and they start killing the tumor from the inside out, they're rapidly reproducing inside of the tumor, then all of a sudden that 2-3 millimeter tumor is now going to be like 7 or 8 millimeters, and it's going to appear on a scan out of nowhere. So the doctors are going to say, oh, the immune therapy is not working, your tumors are bigger, and there's a bunch of new tumors in your liver, little tiny tumors that we didn't see before, so it's not working. So they'll take you off the immune therapy when it's working. And that's really something that is a sad situation. We've seen many patients get taken off immune therapy who actually ended up responding to it. So the way to tell this is to look at your tumor, at your blood, to see if you have any of these exosomes with tumor DNA in them. So what we do, we had this case of a woman who was on, who had lung cancer. The doctor said her tumors were getting bigger. And, we said, okay, well, what have you done to determine whether these tumors are, actually having pseudoprogression? And the doctor said, oh, I did a PET CT. And so the PET CT looks at biological activity. Unfortunately, the PET CT that we described earlier, you can't use it while you're on immune therapy because as I mentioned, the tumor cells and the immune cells both love sugar. So the immune cells inside of the tumor are going to be drinking up all of this radioactive PET solution. So when you do a PET scan, you're going to have a really high SUV and it's going to look like the tumors are really active. So even a PET scan can't detect pseudoprogression. So the only way to detect pseudoprogression is with a liquid biopsy, because those tumors will actually be dead. And the activity within the tumor that a PET scan will see will be the immune cells basically chewing up the tumor from the inside out. And so if this is the case, then you won't see any of these exosomes with your mutations in there. So we did this for this patient with lung cancer. The doctor had said she'd stop responding. She had a KRAS mutation. We looked at the level of her KRAS mutation. It was 1.1%. And so I said to the doctor, this patient is responding. If they weren't responding, they would have a KRAS level of 20, 30%. We've seen it as high as 45% in patients that were near death. And this patient had 1%. So we knew they were responding to immune therapy. And so with this test, we were able to have this patient stay on immune therapy for another year. And the patient responded really well to that. So important new thing. Mm-hmm. So Michelle, would you like to take over here?
Oh, sure. Just a little summary of what we've covered today before we open the floor for questions and answers. So, as I was saying earlier, cancer is a disease of mutation. You absolutely guaranteed have certain mutations that are driving your cancer, probably some of which there is a targeted therapy for. So just keep that in mind. You want to make sure that whatever testing you get looks at fusion genes, mutations, and overexpression. Those are three key elements that can be utilized to make sure you're on the right treatment, to give your oncologist the information they need to prescribe that for you. Tumor DNA helps you to identify fusion genes and mutations, whereas the RNA expression test looks at the overexpression. So the two together, the tumor DNA and the RNA expression, tick all three of those boxes. Mm-hmm. Targeted therapies, because they deliver their drug directly to the cells or the part of the cell that needs it most, have a statistically proven greater benefit. They help people live longer and have a better quality of life while on treatment and after. As you know, chemo, well, you probably have heard or read or maybe experienced, chemotherapy doesn't just have side effects while you're on it. Often it leads to nerve damage that is chronic after treatment. And targeted therapies just don't produce that same kind of consequence for people. As I mentioned earlier, and this is the most critical element, no matter how great of a person your oncologist is, and no matter how much they want to help you, without this data, they can't prescribe anything other than the standard menu within their cancer care agency at this time. With this data, as we were telling you, so many other possibilities abound, including they can just prescribe, and because it might be there in an off-label capacity or available for people with certain mutations. There's also compassionate access, clinical trials, and all sorts of stuff to get you access and coverage that are possible once you know what treatment you really need. As Alex just talked about with the liquid biopsies, it really is the most accurate monitoring tool for cancer right now. It works within a couple of weeks of you starting treatment with 99% accuracy. So you can tell that it really is targeting that mutation, and the amount of the cancer cells in your body really are decreasing. And that's a nice peace of mind for you. Make sure you're not wasting any time and that you're getting the right treatment.
Yeah, and you want to combine that with standard imaging too. I mean, you don't just want to do one type of you don't want to depend on just liquid biopsies alone. You want to combine liquid biopsies with standard imaging and then standard blood tests to really get an accurate description. So
those other two will be done naturally.
Exactly.
Like CT scan is commonly done to monitor, and for follow-up to varying degrees, depending again on your doctor and the agency and province. There's massive variation amongst different agencies within the same province and then amongst provinces in terms of what treatments they're using and how they monitor and follow up. And it's really quite a lot of variation. And that's just the nature of our country, and that every province has more freedom in terms of how they utilize different tools that are available. So I just wanted you guys to have access to this information. Again, it's in your PDF, so you don't need to make a note, but if you have any questions or you ever want to follow up and just kind of find out a little bit more about those things we mentioned, please reach out to me directly, and Alex is available for consultation specifically on your case at any point during your treatment, whether you've just been diagnosed and you're just getting started, or you've tried everything and your doctor has said they have nothing more to offer you. At any of those points, as Alex was telling you earlier, there can be a great deal of value in applying precision oncology. One last thing I wanted to mention is, as part of my work in helping to educate cancer patients and their advocates, my team and I have actually built an online training program, and we're just rolling it out actually in 2 weeks now. And we're looking for people who are willing to test it out with us. There'll be a weekly conference call with Alex and I where you can ask any questions you have about cancer, about your particular care. And then there's 16 different modules that talk about all different aspects of cancer care specific to your type of cancer. So if you'd be interested in learning more and really educating yourself well on the most current approach to cancer treatment, how to access it, and just being the best support for yourself or the person you love who has cancer, I would welcome you to join me and kick the tires on this new program and just really get all that information. There's no cost to be a beta tester of this program, just so you know.
What a great program. That's wonderful.
Yeah, I'm excited about it.
So happy that you're doing this.
Thank you. Me too. Yeah, it's going to be a game changer for a lot of people, I'm sure.
Yes.
Yeah. So now we'll just ask if anybody's got any questions. You can either put your hand up or make a note in the chat here. Anything you want to know about yourself or someone you might be here to advocate for. Any questions you have about their care. No pressure if you don't have any questions, but if you do, go ahead and post in the chat or just put your hand up. All right, looks like your needs have been met at this point. I know that was a lot of information. As I've said about 5 times already here, the replay and the PDF with lots more information than we've just shared with you will come to you in an email on Monday. So a day and a half from now, we'll have all that information coming to you. And I hope that you review it. Any of the information we've shared with you today, you're welcome to share with anyone else, whether it's other cancer support agencies, your oncologist, other people you know with cancer, or other family member and friends. The better educated everybody is about these key elements of cancer and what's possible today, and just how to make sure that the people who are caring for you really are using the best possible resources available. This is good information for everybody to have, for sure. Anything you want to add, Alex, that wasn't in the presentation that's just come to mind, or any kind of last words for people?
Yeah, really, it's unfortunate that in Canada right now, we have to pay for our own diagnostics, but it really is an important thing. If you're in a different country, like the States, you would naturally get tumor DNA sequencing in most cases.
Assuming you had insurance coverage.
Of course, yes. But the Canadian medical system is great for trauma. If you have a heart attack or stroke, they'll pick you up in a helicopter and fly you to a hospital, and you'll get surgery that night. But with cancer, unfortunately, they assume that you have a long time to live and you're not priority. Mr. Smith, who needs a new heart valve tomorrow, is going to get priority. So unfortunately, as Canadians, we all have to pay for our external, testing. but it's such a important aspect of determining what's best for you.
Mm. There is an interesting statistic about that too, actually, which is that in Canada specifically, 2/3 out of every dollar spent on healthcare is spent actually out of the patient's pocket already, whether it's for pharmaceuticals, for massage or chiropractic or dentistry, all of those things, you're already essentially paying out of pocket. Just something to keep in mind. But we do have a fabulous system, as you say, for emergencies and for kind of basic maintenance. It's when there's something like this that can often fall through the cracks. It can take up to 2 years commonly for cancers to be diagnosed because of our current approach to doing that through most people's GPs and how long it takes to get to see a specialist and all of those things. So all this, you're here because you're already in the club. You've already had a diagnosis or someone you love has. So we're kind of preaching to the choir here. But you're not alone, I guess, is what we're trying to say here. Not only are we here to help in any way that we can, but there are lots of folks out there going through the same thing with you and trying to figure out what the best thing to do is and who to trust, who to listen to, what do I need to do versus what can I get away with. And again, when you're really stressed and the stakes are really high, it can be hard to think clearly and it can be hard to know and have confidence in the things that you're doing, especially when they're new. So that's really why we started this service. Both of us lost precious people in our lives to cancer, and we just kind of had enough of seeing what was possible versus what was offered. So we hope that this information has provided you with some reassurance and some hope that there are options, there is more that can be done, and some information about how to go about starting to make sure that you access those things for yourself or the people that you love. So thanks very much for joining us. It was nice to get to interact with you briefly at the start of our chat today, and you know where to find us if you have any questions. Have a good day.